Hello, welcome to all our honorable speakers, chairs, and wonderful audiences all around the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable faculty from the UAE, Dr. Anwar Ahmed. Dr. Anwar is the chairman in the Department of Neurosurgery at the Al Jalila Children's Hospital, Dubai. He was a former consultant at the Sheikh Khalifa Medical City, Abu Dhabi, and he was also formerly working with the NHS as a spine surgery specialist in the United Kingdom. He is a passionate surgeon whose clinical interests are focused on the management of pediatric brain injuries, pediatric brain tumors, and spinal cord tumors. He is an invited faculty to several workshops and conferences all around the world. We are extremely honored to have him today at our webinars, and today we'll be talking about management of pediatric brain injuries. The speaker for the second session of today is our honorable faculty from China, Professor Wu Lingyong. He is the attending neurosurgeon at the Nanjing Drum Tower Hospital in Shanghai, China. His clinical specialty of interest is in cerebrovascular surgery and spinal vascular malformations. He has published several articles in regard to mechanisms of subarachnoid hemorrhage, and we are extremely honored to have him today at our webinars. And today he'll be talking about surgical management of spinal dural AV fistulas. The chair for the first session of today's webinar is our honorable faculty from the Philippines, Prof. Lynn Lucena. She is a neurosurgeon at the Bicol Regional Hospital Medical Center, and she is a diplomat of the Philippine Board of Neurological Surgeons and fellow of both the Academy of Filipino Neurosurgeons and the Philippines College of Surgeons. She is also the chair of the Neurotrauma Committee of the Asia-Australia Society of Neurological Sciences. She has served for several important positions in the past, like Vice President of the Academy of Filipino Neurosurgeons, Chair of the Philippine Society Board of Neurosurgery, and also the Secretary on the Board of Directors for Academy of Filipino Neurosurgeons. She is widely recognized for her expertise in neurosurgery, particularly in the areas of neurotrauma and women in neurosurgery. Her contributions to the field have earned her a reputation as a respected and influential figure in the medical community. We are extremely honored and grateful to her for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable faculty from India, Dr. Kuntal Kantidas. Prof. Kuntal is an additional professor in the Department of Neurosurgery at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. He was previously a fellow of vascular neurosurgery and image guided surgery in Nara, Japan, followed by lateral skull base fellowship from Italy and anterolateral skull base surgery under the mentorship of Prof. Ali Christ at the Arkansas. His areas of interest are surgical neuro-oncology, cranial-based surgery, and cerebrovascular surgery. He is an invited faculty to several workshops and conferences and has also published several novel articles in various peer-reviewed journals. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome all the chair speakers and the wonderful audiences from different parts of the world. A very warm welcome to our esteemed colleagues from China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Lynn Lucena.
Good day to everyone from every parts of the world. So it is my pleasure to chair this session on pediatric head trauma. So I think we would like to hear Dr. Professor Anwar for his lecture now.
Thank you very much for giving me the opportunity to present in such a eminent neurosurgeon all around the world, and special thank you to ACNS and my friend Raja for giving me this opportunity. The topic of the presentation is head injury in pediatric patients. We all as a neurosurgeons have honor to treat patients with head injury. And I often tell my friends that we as a doctor has to treat three types of patients. One is how to treat fever, second is how to treat back pain, and then how to treat head injuries. So head injury is, what is head injury? That is what I want to add here. Is that there's no conflict of interest to declare here. And I've divided my presentations to have a general fact about head injury, how do you assessment of head injury in pediatric population, and my own experience in dealing with different presentation of patient with head injury. As a definition, you have to understand what is head injury. It is an impact on our trauma by miscellaneous cause, and to not only to its head, even its underlying structure or around it, and it causes a significant mechanical disruptions as a result of force and the inertia it impacts. The second important point I want to emphasize is that people consider traumatic brain injury is an event. No, it's a process right from the time of impact, which is rather the primary injury, then the secondary effect, and the delayed effect. So you should not take it as an isolated event, especially when you are dealing with patients with pediatric population. The second important part is that, yes, head injury we all know, but when you are dealing with a patient with pediatric age group, there are significant six group in this population, and which all are not immune to head injury. They all get head injury from mild, moderate to severe. And just imagine a neonate who can have a severe head injury as a result of birth trauma will have a different impact of pathology and effects on physiology. The next group is infant. Infant is a very strange group. The moment you are born, either you are born in 24 weeks or you are born in 28 weeks or you're born in term, you become an infant from that period to the first 6 months of life, where your physiology and pathology are quite different. Then you come to the next group, the toddlers, the most unrestless age group, where anything can happen anytime and any events can produce to head injury. Then we have the second group, which is slightly stable preschool, school-age child, and adolescent, where they are more or less similar to the adult population. But the first three groups give you a great opportunity to understand the pathology in respect to how it affects the physiology. So this concept is very important when you're dealing with a pediatric age group with head injury, especially to their age group. Why I say that is that now it's a general fact is that head trauma is leading cause of death among injured children. 80% of trauma death, traumatic brain incidence range very commonly 10 million people worldwide and 14,000 trauma death per day. And death from trauma accounts for half of the pediatric death, and of which head injury is one of the common cause. Now, when we come to our age group, there, as I said in earlier, there are three main groups I'm just covering is newborn. They are mainly related to birth trauma and which can lead right from the scalp hematoma to fracture to intracranial hemorrhage. But luckily, we most of the time see capsular hematoma. Infants can have both accidental head injury and unfortunately, they can also be a victim of abusive head trauma. Toddlers and school children fall in between. Accidental head injury is more common, but they can also be a part of non-accidental injury. Adolescents can have anything from bicycle or motorcycle sports injury and also a victim of road traffic accident and violence. But when we move this group, we move to the next common group, which is common to anybody, is fall is the most common cause of traumatic injury, and especially in both young children and adults. Vehicle-related collision is very common in low-income and underdeveloped and developed countries, especially in my part of world, also a very high-speed traffic. Violence is becoming more and more common, and it is coming out with gunshot wounds, domestic violence, child abuse, and which in turn leads to a very different group of shaken baby syndrome, which is quite a different sequelae of head injury from what we see in day-to-day practice. Sports injuries are common in especially the preschool, school-going and adolescent. Unfortunately, we are living in a violent society. Explosive blast children are around and giving them a very severe traumatic brain injury, which are mainly in form of penetrating injuries and which can result in a life-threatening situation. And the traumatic brain injury from penetrating wound can have as a sharp nail or sharp object falling on them. And in children, we see them, especially in the nooks and corners, they move and hit hard pointed object and can result in penetrating injuries. These all causes have different effects on their injury, which will come later. Now, this is the concept slide I want to present is that look at the ratio of your head to the body. When you are an infant or when you are neonates, your head is almost 25% of your body size. And as you grow, it turns out to be somewhere 8 to 9%. So the impact of trauma on this first three age group is much, much higher than in the last two age group. And it's also, if you are hit by a car or fall, you will have more head injury than your body injury in the first three group. Now, another important thing to remember is that when you see a child with a head injury and how you compare with adults, you need to know that the trauma history is not clear, because sometimes they get the trauma and nobody has witnessed. Blunt trauma is more common than the penetrating trauma. The third point, which I've already mentioned, head is large, so the impact is much. They also have got some more spine injury because neck muscles are weaker, so they cannot protect their head while falling. The skulls are thinner, scalps are more vascular, so you have a significant blood volume loss in scalp hematoma, any penetrating injury. And children often develops hypovolemia, which does not present the same way what you see in adults. And hypothermia is also more common in pediatric age group, and these in turn have a significant effect on the trauma they sustain. Now, when you are dealing with head injuries, you are always try to see where are the primary intracranial cause and what are the extracranial cause. The extracranial cause is more important till you are not involved with the management to prevent hypertension, hypoxia. Patients should not be hypoglycemic, hyperthermic, and then some other associated that coagulopathy, or these are in late time, whether they have been suffered with ventilation issues. And then the impact will cause you intracranial like a hematoma, cerebral edema, hypertension, and if these are not there later, CNS infections and seizures. All these have an direct and indirect impact on the head injury, and especially we see in our pediatric age group. We were thankful to T-Cell and the group, and now it's almost 50 years, that one way we can very clearly assess the severity of head injury by the assessment of Glasgow Coma scale. And in this, everybody knows what are the components of Glasgow Coma scale. But what is the difference between a Glasgow Coma scale between a school-going when an infant or a toddler? And the difference is only in the verbal response they do. They cannot be talking to you, so they will do cuckooos and bubbles. They will not be confused. There will be irritable cries. They will not say inappropriate words. They will cry to pain, moans to pain, and no response is the same. The other is the motor response. You cannot ask them to obey command, but pay attention. Are they moving spontaneously or purposefully? Are they withdrawing to touch, or they are withdrawing to painful stimuli? How, and then the abnormal flexion and extension is more or less the same as we do in adults group. When no response goes the friend. So in assessing a Glasgow Coma scale in infant and child is slightly tricky. So you have to concentrate on the verbal, eye opening is fine, and the motor response. One thing I also want to assess that the initial GCS does not mean that if somebody is low in GCS, will always have a severe injury, because concussional injuries are severe in the initial low GCS in the initial stage, and then they gradually improve as compared to a life-threatening extradural hematoma. You are quite conscious, walk and talk, and then you go unconscious. So a serial and a continuous assessment of GCS in any patient of head injury is very important part, which we always have to pay attention. And especially when you are a referral centers, you have to find the sequence of event, how did it started and how the child has progressed. When you're doing a Glasgow Coma scale, I add this also. It's been very useful to have pediatric trauma scale. What is the size of the baby? Is it less than 20 or is less than 10? And you score them by +2 to +1 to -1. How was their airway? Were they able to be maintaining normal airway, or they were unmaintainable? What was the systolic blood pressure? It gives you a clue that it's just an isolated head injury or you're dealing with some other trauma. What was the GCS, which is very important to us? And then is there any open wound? And then is there any skeletal fractures? So if you add these two scores in an assessment of a patient with brain trauma and head injury, it gives you a fair idea about what are you going to deal with in your ER or what patients you have been referred. And we all know in this that grading of head injury is done on the basis of Glasgow Coma scale, not on the basis of severity of injury like a scalp or a fracture or a hemopneumothorax. What is your GCS at the time of presentation? Do you have any loss of consciousness? Mild is when you have dropped one on the GCS and there's a loss of consciousness less than 5 minutes, and decrease alertness on amnesia. This is something we always forget to ask. Then is the moderate, and then is the severe group. The severe and critical are very simple because from the start you know what you are dealing. But the trick is that a mild can move to moderate and the moderate can go to severe. So assessment of head injury on the basis of Glasgow Coma is a very assessment tool, and this has to be followed with the other focal signs. When you have this information, you also know how you are going to assess the prognosis of what you are dealing. And I always say that GCS at presentation may or may not be misleading, but it is giving you good information. Age is another important factor. The finding of people says you whether there are signs of raised intracranial pressure or there are signs of herniation from the start. And the most important physiological variable should be what was his oxygen saturation and how was his blood pressure. And then you definitely see CT and MR finding and assess them on the basis of Marshall criteria, which very clearly shows what is the assessment of the head or what is the severity of the head injury. Now, I'm further breaking it to when you're assessing a patient, you do not assess only on the basis of Glasgow Coma scale. You also have to assess on the basis of the clinical symptoms what they are presenting. Are they presenting with loss of consciousness, nausea, vomiting, there are any concussion injuries? Then history as any clinical assessment is very important. And then you correlate these two to your diagnostic images and then anticipate all these three factors, how it's going to affect your patient which you are going to deal with. Now, I pay special attention to the history that you should know and understand the mechanism of the injury. How was it? A height of 1 meter or a height of 1.5 meters have a significant difference. A child running on the or a child was walking, or a child hit by a car, or a child hit by a fall from a height. So mechanism gives you a clear idea about what will be the effect of the injury. Second is that what was the loss of consciousness duration? Did he have any seizures or not? These are always missed in pediatric. Was there in his current headache, or especially in adolescent and child, is the headache is getting worse or better, or this is very important to guide you about what is happening intracranial. Nausea and vomiting is more common in concussional injury at the start, but it goes worse when patients are developing raised intracranial pressure. And bleeding disorders in children should be also considered in taking an acute assessment or in the history. I take examination should not be focused only on GCS. It has to be right from the head to toe. And I say that scalp is very important because head is scalp, and scalp has to be assessed for the presence of any hematoma, laceration, abrasion on the scalp, and whether if the laceration is it full thickness. Later in my presentation, I will tell you how many times scalp injuries are missed because it's not being assessed. Palpation of a skull fracture, and in neonates and infant always feel the fontanelle. How do you feel about it? Is it bulging, firmness? And also some assessment on the head circumference. Focal neurological symptoms are always important when you're assessing in general, and then sometimes look for the evidence of a basilar skull fracture, means CSF ortoria, rhinorrhea, any raccoon eyes or battle signs. Neuroimaging is fashion. If you don't do it, it becomes a crime. But if you do it, then you have to be sensible why you are doing it. It should be assessed when you have a focal neurological finding. If you think there's a concerns of fracture on the examination, the GCS is fluctuating, the child is irritable, bulging fontanelle with persistent vomiting, prolonged loss of consciousness, or when you have some concerns of child abuse or you are not clear in the history, then it's better to have an imaging so that you can have an assessment in respect to the physical findings. When not to image is also important. We know that 80% of the head injuries are minor. If the history is clear, the GCS is 14, 15, the child has got no risk factor, and there is no loss of consciousness, no skull fractures, and parents are sensible, then you can give them a clear instruction what to monitor and no need of doing imaging at that point. The second important thing is that what is the head injury we are talking about? The head injury itself, as I said, is a process. And this process is mainly related to the primary brain injury, which in turn leads to the structural and functional changes. It does not matter in the scalp, which I'll come later, but it's very important how it affects the brain itself. And in this way, it turns leads to cerebral edema, which in turn leads to intracranial hypertension. And on the other hand, if you have secondary insults like hypoxia, hypertension, seizures, you will add to more of these structural ischemic changes, and which in turn leads to secondary brain injury. And this has a implication, and this is what we are in. Our role is important, that we prevent secondary brain injury and we take steps that the secondary insult should not happen. It just in terms of brain, I'm just talking about when you have a primary insult, it affects the cerebral autoregulation, metabolism, and it is mainly seen in concussional diffuse axonal injury, contusion, or hematoma, which in turn leads to increased intracranial pressure and hypertension and brain shift, and which is life-threatening. So if you know the mechanism, if you understand the pathophysiology, you can easily plan your intervention. Luckily, we see more minor head injury, but we think that just patting the child and giving them reassurance will cure them. No, it's wrong. You have to know that 60% of the children with minor traumatic brain injury can have symptoms, especially in the school going and adolescent. The headache can vary. So keep them on follow-up, see whether there's any issues later of any thinking and memory, moods, and sleep difficulties. And these are seen rarely in the centers where patients are not being followed after a head injury or there was some finding in the initial stage. So my emphasis is that as those who are dealing, please, head injury is not one event. As I said, it's a process. You should give them follow-up till you think that the child and the parents think that they have regained their normal status. When you're dealing with a child with a severe head injury, you do not think that just ventilation and sedation will solve the problem. There is a difference in anatomy and physiology, and it is in the different stage of grade. How they are, what will be the response if you hyperventilate? What are the volume you want to maintain, and CVP, hypothermia, and you should take more quick measures to prevent seizures in this age group as they are more common. And then you take steps to prevent elevated intracranial pressure. So neonates and infants, although in severe head injury, needs a totally different phenomena and assessment and your intervention. We have a lot of said about severe head injury by two great society, European Brain Injury Consortium and American Brain Trauma Foundation. And it's been laid down for a long time, almost now we are 25 years from that. And this is very clearly is directed to severe head injury, but you don't find any guidelines for the 85% of the head injury, how you deal with this with a large scalp hematoma. This everybody knows is being multifactorial. It is care is divided between you, the ICU, the intensivist, and any other physicians who are interested in head injury right from, and later on. ICP monitoring, I'll come later, then the threshold of ICP, then what treatment modalities you need to take while controlling the ICP, seizure for prophylaxis, and then going to the barbiturate coma. Corticosteroid was very much in fashion, but from NAS1 Noich 2, we know that it's no more help in head injury. This is my most interest part. We forget head injury and we forget scalp. You know, scalp is a is a mnemonic of skin connective tissue, aponeurosis, loose regular tissue, and periosteum up to the bone. And I will tell you, in my practice, 70 to 80% of head injury in pediatric age group is in the scalp. Then there's a transition to the brain. And this injury is not minor. Just say this is the child of a 3-month-old mother comes that my child fell down last night. He was fine. I left. This morning, I see this. You examine the child, you see the child has got a large bump. What you will do, the important thing is that should you scan the child or you assess, what I usually think is better to examine the child with on the basis of clinical hemodynamic. But most important thing is that is it an unusual size of a scalp hematoma? So you should always check the hemoglobin and also the clotting profile. And if you are worried about any raised intracranial pressure, as I said, use the criteria for imaging. And if it fulfills, you do that. Second is that birth trauma. I was lucky that sometimes they present with seizures, and in this situation, they have a large scalp hematoma with no underlying, and this could be multifactorial. So you should assess the size of the scalp hematoma and where, and is there any underlying fracture or any brain injury. As I said to you, this is a very classical example. This poor girl had a polytrauma. He had a fracture of her femur, a pneumothorax, and a fracture of the lower limb. And she was bleeding from the scalp, and she was transferred from 3 unit. She was bleeding from the scalp, and nobody bothered. They put a head bandage on it and wrap her and sent from 1 unit to other. When she came to our center, we found that she had dropped her hemoglobin from the initial 10 to 8, 12 to 8, 10, and then to 9. And when somebody opened, we found this degloving scalp injury, which was missed in 2 centers. So please shave the hair, assess the scalp, and this is very important. You can miss that. Degloving injuries are very fascinating in the ER situation, but don't mess with them. Clean, just wash and cover, bring them to the OR, do the imaging, and then do a proper assessment. And there's no underlying brain injury. They usually heal well and they do very well. This is interesting. You will see children with different lumps and bumps related to head injury. The first one was a child who had a capsular hematoma on the right side, which did not resolve, and it takes time. There's no set rule for capsular hematoma or scalp hematoma to finish. Then this is a child who had a large head of subgaleal hematoma, and it took long time to settle. And the third one is an unfortunate child who sustained a severe scalp injury as a result of cesarean section, and it led to almost a life-threatening injury. So, and if the scalp hematoma is not being dealt with or not being managed, it can lead to larger and abnormal shaped head with a capsular hematoma. It is usually dealt later in life. I usually wait till they are 5 or 6 years old because the skull is growing, and if you do any intervention earlier, most of the time your implant or your cranioplasty will not work. This is another interesting case. A child who had a large scalp hematoma was admitted in an ICU. Poor child developed neonatal sepsis. And then because of some reason, the scalp hematoma was forgotten and was covered with a head cam. And the child was spiking and everyone was paying attention to the sepsis, but nobody saw what's happening. And this poor hematoma has transformed into abscess. And then in this time, there's always a turf of war, whether this is pediatric surgery or pediatric neurosurgery. There's let the child make our life easy by putting an abscess out of the scalp and underwent an urgent drainage of the abscess. And unfortunately, this sepsis led to meningitis and later required a shunt. But I'm just telling that simple problems can get into a life-threatening if we don't pay attention in the right time. As I said to you, this is just the scalp I have touched and the problem. Now we come to the skull fractures. The skull fracture, we all know, is more common in the first 3 age group because the skull is thin, a linear fracture, a depressed fracture, diastasis of sutures, and then the basal skull fracture is mainly related to the impact injury. The first 3 group is very important. The linear fracture does not cause any serious sequelae, but they usually result in large size scalp hematoma. The first case I told you, the depressed fracture looks very fascinating, but It doesn't need much doing nowadays. With just a vacuum suction or a single burr hole, you can elevate. Diastasis fracture, in turn, does not need any acute management, but it is important that the sutures diastasis lead out of proportion more larger size scalp hematoma. And basal skull fractures, usually you have to assess what is it causing. Is there any CSF autoria, rhinorrhea, and is it affecting the child eyesight, which is important to understand in my next slide. This poor child, he's only 4 years old, and he fell with an elmira fall in his eye, and this is his skull CT with no underlying cranial. But you see the impact of this child is that because of his bilateral raccoon eyes, he turned out to be a blind child for at least few days till the eyes were not open and the amount of stress he had. So in that situation, your empathy and dealing with him and the parents plays a more role than you, and you have to understand the pathology as compared to how it's affecting the physiology. Here is not the physiology of raised intracranial pressure. Here is a child who could not see for the first few days after this injury. His GCS was 15. So we have to be patient. We started doing some cold fermentations, and later on, and once the eyes start opening, everything settles. And this is very common practice. You see children either by fall or some unknown mechanism, they present to your ER. Their parents are very worried, but I usually reassure them. I don't do them on the first. I give them few weeks, and sometimes it remold itself, but if it doesn't in 2 to 4 weeks, then you plan a mechanism what to do and how to elevate. Because you have to understand, I heard one of our famous speakers, decision is not incision. Decision is a collective experience and your practice, and which is very important to understand. Sometimes you have to do it. When you have to elevate, if the child is more than 6 months and you affect that it is full technique, it is causing compression in the eloquent area, and there is a reliability of follow-up is not there, then you can do a simple, I usually expose the whole fracture line, raise do a simple, I don't do with burr hole, sometimes I do a craniotomy, elevate the fracture and put it back, and it has got a much better effect. I will rather happy to hear the comment on this. Sometimes the skull and the imaging looks very fascinating, but you have to see, you don't treat scan, you treat patient. If your patient is stable, he has shown no signs of raised intracranial pressure, he's feeding well, you just sit tight and reassure and monitor the child. And most of the time, when the hematoma settles, the fracture comes to its place and it heals. And there was some underlying contusion, so you have to give them some seizure prophylaxis. So here the message is, don't treat the scan, treat the patient, evaluate it, and then get the best result. This is a child who had a fall backward, and he has resulted in a diastasis of his sagittal suture. He has more of a concussional injury, vomiting, little bit more sleepy, but in the next 24 hours settled down. But you see, he has a very boggy scalp swelling, and here the main issue was how he should be nursed. He should be nursed not supine, he should be nursed lateral or slightly semi-lateral so that he does not have any pressure effect. And because whenever he lies supine, he starts more vomiting, change in GCS. So this was the trick to monitor if you have large size scalp hematoma, which is in the midline posteriorly. You have to learn how to nurse these children. Sometimes you have two types of fracture, either a linear and a depressed, and these are straightforward. Don't waste your time with GCS. They are usually first-line surgical treatment, and they have a very good outcome. And sometimes you get simple case like this, where there's a depressed fracture with an extradural hematoma, child was vomiting, headache, and you just, in the next available list, you take them to the OR, elevate the fracture, fix, drain the hematoma, and they do fairly well. Fracture does not only give you simple injury. As I said, it is related to the impact and velocity. So you can sometimes have fracture, not that, but they can have a very underlying effect on the brain, and which you can see is that the diffuse cerebral edema, which was compounded by hypoxic anoxic, and this child has definitely a very poor outcome because of the result of his head injury. And sometimes follow-up of patients are very important. The initial scan may not be so convincing, but later on, if they develop this chronic subdural, there's usually an increase in head circumference, mild symptoms of raised intracranial pressure. So I see that every fracture patient should be followed at least for 6 to 8 weeks, because there are consequences, and which are like subdural growing fracture. Basilar skull fracture, more important is that whether you have CSF, rhinorrhea, or toria. And if you have petrous bone fracture, please evaluate the facial nerve and adhering in due course of your management, because these are sometimes affected as a result of fracture. And what is this? This is the same, the child where a linear fractures which was not followed, and later on poor child developed ingrowing fractures as a result of a loss of follow-up, and which has resulted in absorption of the bone. And this is as a scan. I think I also contribute this to the maybe a communicating hydrocephalus, which has led to the reabsorption wound. So the management was planned to do a cranioplasty later. Now I go to the next group, which is brain conjury, which is basically the more forceful impact, and it causes contusion, and most common contusion are seen in frontal and temporal area associated with surface contusion to the deep. And it depends on the size and the number and how it is. And these hemorrhages, when petechial hemorrhages, coalesce, it leads to intracerebral hematoma. So the message is, if you get an initial contusion in any children, you should do a follow-up scan in 6 to 12, either 12 to 24 hours. If there's any change in new neurology, you should do it earlier, because there is a chance that this can progress. Hemorrhagic contusion, as I said to you, can lead to hemorrhage, and this can lead to herniation and can cause more serious consequences. Now, sometimes the injury from the outside does not mean that it will not have severe injury. This was just concerned as a scalp laceration, no scan, and we later on found he has got a large acute subdural hematoma, underwent craniotomy for evacuation, and had a seizure. It stayed longer than we expected, but at the end he was discharged with no focal deficit. Extradural hematoma is a very important part, but what is important to remember in children is that what is the size, what is the site, and what is the duration. If they present to you within the 6 hours and the size is small, you don't need to rush. Anything more than 1 centimeter with a midline shift and location in the temporal area should be evacuated in next available list. Hematoma which are less than 1 centimeter on the frontoparietal area with minimum mass surface can be managed conservatively, and I've seen you don't need to remove large extradural if it is not causing any change in the clinical GCS, raised intracranial pressure, and they come to you late. The point is that what is the duration of the injury and what is the findings on the scan. Subdural, I consider it's more life-threatening because it is underlying hematoma with some brain injury, and it is more neurological signs of raised intracranial pressures are more, and you have to use your Marshall criteria to decide when to take it, but I consider it to be drained sooner the better, and the outcome is better. As this patient, the history and the mechanism was not that convincing, but the patient was on some hematological disorder. So the size of hematoma can vary according to the their clinical presentation and underlying disease. Diffuse axonal injury is seen in high impact injury in children also, and you have to see what is the initial GCS, what are the findings on the scan, and what are the focal signs, and if they are on a support on the management of non-surgical, then you have to follow a protocol, which is Usually you take general measures for these patients in terms that you make them head up, you sedate, ventilate, you maintain. But I will say that ICP monitoring is very important, and ICP and CPP will guide you when to do either a barbiturate coma management, or you do a decompressive craniotomy. In children under 3, decompressive is not commonly done, but it is done when needed. And we also found that luckily the moderate and severe head injuries are less common, but unfortunately the disability in this age group is quite high, and 61% according to this study has found severe disability in moderate to severe traumatic brain injury. When you're doing the intracranial pressure assessment, it is different in children as compared to adults. The range varies in newborn from 0 to 5, in infant 1.5 to 5, and 3 to 7. So in that way, your CPP will also be different. And the point I'm trying to say, if you're doing an ICP monitoring, ignore the surge of raised intracranial pressure when they are at the mood of weaning of their sedation, because there is always a tug of war between us and the anesthetist. What is the optimum ICP when we should intubate? And we go with the clinical finding, constant low ICP for more than 24 hours. Your scan looks fine, basal systems are open. There's no reason for them to be kept sedated and ventilated. But there are occasional surge of raised intracranial pressure, because when they try to reduce the sedation, they start coughing and sneezing, and that means another dose of thiopentone, and then you stuck another 24 hours. ICP monitor, as everybody, as a neurosurgeon, we use the same criteria. If you cannot monitor clinically, you should have an ICP monitor. We prefer it to be any patient who is sedated, ventilated for any reason with head injury should have an ICP monitor. It also helps you to direct your treatment to maintain the cerebral perfusion pressure on the basis of ICP. ICP can be monitored in 2 ways. Either you do intraventricular or intraparenchymal. These were used in the past, but intraparenchymal and ventricular are more important. Their advantage, the intraparenchymal is easy, more accurate, but it is cost effective. Intraventricular are better therapeutic, but difficult if you have got brain edema or sometimes underlying confusion, it increases. But it depends on your own expertise and your unit practice, plan it. But I will emphasize that no head injury patient should be monitored without an ICP if they are ventilated and sedated, even though their Glasgow Coma Scale was initially good. And as I said, this in pediatric age group, the cerebral perfusion pressures are different according to their age and physiology. So if you are under 2 years, you don't need a mean pressure of 65 or 70. You just need below 50, 45, 2 to 8 years between 50 and 60, and above 8 is 60 to 70. So this is important because you don't want to create high perfusion injury, or more of the hematoma or the mass effect can increase. This is a very interesting question, hypertonic saline or mannitol. I will say that unfortunately hypertonic saline is not available in most of the units, but if you don't have hypertonic saline, you should mannitol. But hypertonic saline is preferable in pediatric age group. It increases the volume, it decreases the hyponatremia from cerebral salt wasting, and it prevents seizures also. Well, how much to give? It is a simple formula. You have to give them in dose of 2 to 5 ml per kilogram body weight in the initial loading dose, followed with a maintenance dose of 0.1 to 9 milligram per kilogram. And 24 to 48 hours, you have to monitor the sodium, and should not be below 140 and not above 152. One important thing is that as a neurosurgeon, don't focus your attention only to your patient with the head injury. You are responsible for your patient as a whole. And we often forget the nutritional part of our patient in acute and severe head injury. They are managed for the sepsis and other things. Nobody is seeing what is the caloric requirement. And this is a child we inherited from although from a war zone, but poor guy was looked after everywhere, but nobody considered him. for his nutrition. And this is a picture he had when he came in, and this is on the right is within 6 weeks, where we just managed to make his nutrition according to his caloric value, and it made a significant difference in his overall outcome. We could not prevent the contractures he developed, but we at least made him more human and more healthy. And this is the same comparison I said. And I will very important say that as in pediatric age group, nutrition is very important. They go in a catabolic phase if they have more than one system injury. You can end up with complications. Don't shy. If you do a craniotomy and you develop an infection, this is very interesting. In children or adults, if you have an infected bone flap, it has to come out. You treat the infection and then think about cranioplasty. Don't try to think about cranioplasty and let the infection brew, because it will have more serious consequences. And sometimes children are not followed, and then they develop this subdural, which has got a very high impact on the intellectual development. We all know children brain grow in the first year of life. If they have sustained a head injury in the first 3 months and then not been followed, and then they come to you in the 6 months with a large head and large subdural hematoma, will affect their brain development, which you can very well see from both this scan. So I will just come to after all this, that yes, it's a very challenging and dynamic injury to our population. It has got complications, CSF leak from 2 to 6% in closed head injury. Seizure is seen in closed head injury if you have contusion, intracranial hematoma, or depressed fracture. Facial injuries and orbital injuries should be monitored for caroticavernous fistula, carotid cavernous fistula. Diabetes insidious is coming up these days, because in a diffuse axonal injury, the line of force affects the pituitary axis, and these patients can have severe diabetes insipidus during the course of intubation or later. Infection in any patient in ICU is high, and post-concussional syndromes are seen in minor head injuries. What all to remember is that you have to be a physician who should take the history with the clinical symptoms, the diagnostic images, and should evaluate all together with your common sense, which is most important part. Life-threatening brain injuries will gives you a narrow window. So your intervention should be planned, especially when you're getting patients from transfer center. Don't wait for the ICU. There should be a golden period. We have missed a lot of opportunity when patient is being transferred from one place to other and cannot be dealt. So this is very important. You have to be on top of everything when you're dealing with the life-threatening injuries. Time is brain, and brain is time. And prognosis, I said, when you're dealing with head injury, depends on GCS at presentation. Higher mortality is under 5 years, and if you have papillary findings, you have got more serious consequences. These are my patients in different age group which I have dealt with, and mashallah, they're all healthy and living a normal life. Thank you very much for your attention. I'm honored to be ready for questions.
Thank you, thank you for your very comprehensive and very extensive lecture on pediatric head traumas. So are there any questions from the ones who are watching?
So far, there are none from the chat box.
Okay, maybe I'll ask a question first, Dr. Anwar. First of all, in the diagnosis of head trauma for pediatrics, sometimes they may come early, and you do not know whether they are already having some problems inside the brain, right? So they are very they're crying a lot. So you do a scan, for example, as you said, you do the imaging. But then again, it's maybe less than 6 hours and you do not see anything inside. So after that, how do you recommend if you are, how many hours will you do a repeat scan, or are there any other modalities? Because some parents may be worrying about radiation or exposure to radiation.
As I said to you, that when you're assessing the patient with any head injury, the emphasis is to be on the mechanism of injury. Okay, that's very important. If the child has fallen from 1 meter bed height on a carpeted floor, I will and came to hospital within few hours from the start, I will monitor. I will do a baseline, and I took certain criteria. If there is a positive scan, I do scan them in next 24 hours, irrespective, because they change. There's a dynamic, as I said, it's a dynamic process. But if the scan was normal, child is remaining clinically well, no, and there's no signs of raised intracranial pressure, I usually go clinically. And my instructions are very clear: image if there's new neurology, new change in GCS, or seizures. Okay. And parents, I tell them that not doing a scan for a child can be more serious consequence in the complication of. We do a low dose protocol scan, and which should be practiced in pediatrics. That don't you need to be focused on the volume radiation dose. So we have made a protocol to do a low dose scans, particularly to assess the fracture or any contusions or hematoma. So that's my own practice.
Thank you. So other questions?
Takashi Kon, would you like to ask something?
Yeah, thank you very much for very informative lectures about pediatric head injury. Because our experience is very rare, but sometimes head injury, pediatric head injuries, very severe complications and severe conditions. And I would like to ask you one question about just after the born neonates, cephalohematoma, distinguishing from cephalohematoma and the later case of growing skull fracture.
Yes.
That cephalohematoma is easy to overlook a cephalohematoma, but sometimes became severe complications. So how to distinguish between cephalohematoma and growing skull fracture in the first stage? Sometimes our neonatal doctors sometimes overlook only to be a cephalohematoma. So in that case, do you have
what is important is that as you know, you will know from the history what was the mechanism of labor, what instrument was used, whether forceps or vacuum. This gives you a clear idea. Most important factors is the clinical consequences of the child. The child dropping hematoma. Then your initial scans guide you how you are going to monitor. As I said to you, that if the underlying brain looks normal, I don't treat aggressively because children have got thin bone, their fontanelles are open, sutures are wide. They can take pressure much better than when their skull is closed structure. And ingrained fracture will never happen in the first 4-6 weeks of life. Okay, it is a process. When the dural is there, you will feel a pulsation on the swelling, which you don't see in a hematoma, which is a very important distinguishing feature, which I found it to be very useful. And then is the sequence of imaging will give you, because a linear fracture will definitely start separate reabsorption of bone, and that is what is usually. And as I said to you, that ingrained fracture should be dealt on the size and the location. And if it is, I have not seen in neonate as common as compared to the toddlers and school going children, where there was a fracture, there was a small scalp hematoma, and it was unnoticed. And then gradually it was considered that it's just a scalp swelling, it will settle, and then it lead to the further widening of absorption of the bone. So clinical assessment, serial imaging, these are the two essential tools to assess that. I don't know any other things I can tell you at this point. Okay.
Thank you. Thank you. Yes, I understand. Thank you.
Thank you very much. If I may ask one question, is that there is very high incidence of epilepsy when a pediatric patients come into emergency. So how do you follow it up? Like, when do you exactly stop the AEDs? Is it
I think
as adults, or you continue it for some more time?
in children, what is most important thing is that you have to assess the risk factor, the mechanism of injury, underlying contusion, especially if it's frontal or temporal contusion more than 2 centimeters, and there's a doubtful history. And I considered a short course because acute. There's been various studies and say that anti-epileptic seizures medicine in the first week prevent early seizures, which is first to 7 days. They have no long-term effect. So if you feel like this child had seizures, if you feel the brain contusional injuries are multiple and they are in the frontal and the temporal seizure zone area, and if you feel that there was a past history of seizures, or they have seizure disorder, they should be started an anti-seizure medicine. 7 to 10 days is enough. You don't need to taper it off. You just give them, and nowadays trend has shifted. Initially, we used to give phenytoin, which has some side effects, but Capra is a very safe drug which you can be given. Initial loading dose is 20 milligram per kilogram body weight. Then you taper it to 10 to 15, and twice a day, and then it can be stopped within 7 to 10 days. But if there is seizure, then you continue for 3 months. You do an EEG to make sure there's no underlying epileptic focus, and then you stop.
Thank you. Kuntal, would you like to ask something? Unfortunately, yes. Yes, please.
Yes. Dr. Anwar, very nice presentation.
Thank you.
Greetings from India. Very nice. And then can I ask you about the long-term neurocognitive outcomes?
Sorry, I couldn't hear you clearly. Long-term prognosis?
He's asking about neurocognitive outcomes.
Yeah, you see, I'm lucky that we are.
They have better neuroplasticity in comparison to the adults.
Yeah, but Dr. Kuntal, the problem is that it depends on what age group you sustain the head injury. In the first 2 years of your life, your brain is developing and evolve, and in that stage, if you have any frontal or temporal contusion, these children have a little more impact. I agree with the plasticity, but it depends on the severity of the injury and what age group and mechanism. And the other thing nowadays, we have got very good neuro rehab facilities and speech language and the neurodevelopmental people. So we involve them from that, and they are the one who follow them for long term. But unfortunately it is seen still, and its most important part is that they are left with seizure, and seizure have its own implications. And then cognitive wise, basically the most important part is their memory is not as good as the children who has minor or moderate head injury. But I take help from my rehab and neurodevelopment physician, and they follow them up. So this is all I can say.
Yeah, thank you. Very nice.
Okay, so are there any more questions? I just have one more. What about the transcranial Doppler in patients, in pediatric patients? What is your experience?
Yes, I will say that I'm lucky to have a ICU consultant who had an experience. And sometimes, my decisions to put an ICP board in child who's been intubated for some sort of a mild or moderate head injury with a lung contusion, and he has to be ventilated. So I use Dopplers in those situations if there's no peak waves of raising tract, or there's no vasospasm in the MCA, carotid artery. So this has some implication, but it's rare cases, but I find it useful, and I've been also forced by him to put EBD on ICP monitor if he makes me that he's not happy with the Doppler's peak waves, which he is expert to guide me on that. And I think it's a useful tool if you have in your ICU. It helps to make decisions much earlier to prevent secondary brain insult.
I think Dr. Simon Ilunga, you have a question?
Dr. Simon?
Dr. Simon?
Yes, I would like first of all to say a great thanks for his insightful presentation. So I would like to know if there is some antibiotic which is given for avoiding infection.
In infection, there is some controversial. I think we are worried about infection, especially when there is CSF, orthoria, or rhinorrhea, or if there is any penetrating injuries or compound fractures. I personally think that CSF, orthoria, rhinorrhea, we are not giving antibiotics because this is the amount. It's a unidirectional flow and it prevents bacteria. But if you have a penetrating injury, there's a breach of dura from a compound fractures. We start them antibiotics. We take a culture when debriding, and if the culture is positive, we treat according 2 weeks. If it's negative, we stop after 5 to 7 days. So, and second factor is that the child in general, if a child has some immunity issues, they are not have got any other disease like, then we give them antibiotics, but not on long term. And we monitor them very carefully with the CRP and ProCalc during this period. If it's rising, we do pan cultures and then we give them antibiotics.
Okay, thank you so much.
Thank you.
We can wind this up.
Yeah, we have exhausted the questions, and we would like to thank our speaker for that very comprehensive lecture, and also all the insightful answers. Thank you so much, Professor.
Thank you very much. Nice to meet you guys.
Yes.
Well, thank you very much. I would like to mention that this has been broadcasted on WeChat, YouTube, and Zoom, and thanks to Professor Shubin. And we have around 450 people who have logged in through different channels. So thank you very much, Prof. Anwar, for this very educational session. And thank you, Prof.
Thank you very much, Raja, for giving me this opportunity.
Most welcome. So now we can move on to the second session, and Professor Lingjun Wu is ready. So we can hand this podium over to our second chair, Dr. Kuntal Kantidas.
Thank you, Dr. Raja. Thank you so much. It is indeed a great pleasure on my part to be part of this webinar conducted by ACNS. I think these webinars have been organized for the last 4 years on a weekly basis, and these webinars have really become very, very important tools, not only for the younger generation of neurosurgeons as an educational tool, but I think the younger neurosurgeons also look up to these webinars as a means of updating their knowledge and their skills. So it is indeed a pleasure for me to be here this evening. So today we shall be discussing a very, very important topic, which is spinal dural AV fistulas. And as we all know, spinal dural AV fistulas, they are not very common, yet they represent the commonest spinal vascular malformation that we see as neurosurgeons. And these malformations are very important to know for us because these malformations can sometimes be missed and misdiagnosed. The reason being the presentation is not very specific, and the imaging features are subtle, and sometimes they're confused with the more common pathologies like an intramedullary tumor. When there is inside the cord, there is a lot of edema and the phloids are missed. So leading to delay in diagnosis. And as we all know, diagnosing these patients on time and offering treatment is all that makes all the difference. And let me also tell you that this remains one of the few indications in the current era where microneurosurgery still has clear advantages over endovascular therapy. So as neurosurgeons, I think we should all know about this, and we should know how they are to be treated, what are the subtleties. And with these things in background, we have a very wonderful speaker with us today, Professor Lingjun Wu, who is an expert in this field. And without taking any more time, I'd like him to kindly take over the presentation from this time. Thank you.
Okay, it's my honor to give a presentation here, and thank you all. And my title is the surgical treatment for the SDAVF. I'm come from the Nanjing, China, the Drumtown Hospital. And the SDAVF is a rare disease and with unknown etiology. It accounts for the 60 or 18% of the common spinal vascular malformation. And the clinical manifestation and imaging finding may be the non-specific and misleading. So the spine DSA still considered the golden state for the diagnosis. However, right now in our corner, and HDMI of the spine is increasingly being used as a screening tool. And the intervention procedures for the treatment of SDAVF have become increasingly sophisticated. However, they still cannot approach 100% success rate. And this disease incidence about the 5 to 10 cases per 100,000. The male affected population is a mid-aged man, and the average of the both male and female patients is 54 and 63 years old, and only 1 to 4% of the cases occurring the people under 30 years old, and the male patient versus female patient is 6 to 1, and the segment of the pie code is focused on the middle thoracic vertebral and to arm lumbar vertebral. In a 2/3 of patients. And the SCVD atoning, the RA is connected to the RV at the point of the festival wall on the nerve metadura, and the interval was congested and attenuated to the spine SD and swollen due to the spine cone edema. And this DSA demonstrates that it's SDAVF at the familiar level of the right L1, L2 vertebra, showing the single atrial feeder of the fistula and the RV drawn into the CV. And we see this one, and the DSA area labeled with the F mark and the different atrial feeders of the fistula. From the first left lumbar artery in A, and from left D12 and the D11. So the SDAVF referred to the artery supplying the spinal dural matter, the nerve road passing through the dural matter of the intervertebral foramen, communication with the spinal drain vein on the dural matter to form a fistula, result in the concentric bonding entering brown fluid direction into the vein. So you see that if we conclude the fistula, the color of the vein gets into the darkness. So nearly 80% of the SVD lesions were found between the T6 and L2, and only 4 are located in the sacral region, and only 2% in the high nerve segment near the familiar, and extreme rare in the lower. Patients rarely have more than 1 fistula, so in our center, most people just have the 1 fistula. The single center study in the Qilu Hospital said that the 82.5% of lesions were located at the T5 to L5, and the most common site was the T7. You see about the 20.6%, and then the T6, T5, T9, and L1. And another study in Toronto, Canada, found that 94% fistula was located between the T5 and S1, and they found the same result that the most were located in the T7. This result is just the same in the study in China. And the tendon to the left side is the most side. And the fistula floor, and how to assessment of the SDAVF, the fistula floor and the number of the somas and conclude rate moments. The relationship between the two factors influence the degree of the development of the progressive edema, which in turn predicts the severity of the clinical disease. The higher the blood flow of the fistula, or the more number of the non-function nerve root veins involved, the lower the expansion of the ventral stream to the subdural space, and the greater risk of the spinal cord edema and the spinal cord dysfunction. The severity and the clinical manifestation of the spinal cord edema and the external lengthening of the arterial drain veins depend on the severity of the root vein occlusion. And the etiology of the SDAVF remains unclear. Some studies based on the improper dural fistula has been attributed to the venous thrombosis of the factor 5 deficiency, and some regions that the SDAVF may be due to the reopening of the supposed root vein. Many suggest that the root vein convolution turbulence is one of the possible causes of this disease. However, there's no direct evidence for the association between SDAVF and the subtopia. Just the clinical manufacturing of the SAD. After system, including the sensory and the motor defects, typically deriving from the foot upwards, and the initial symptom may be mild and usually non-specific and including difficulty in walking, just like running. And 24% of the patients have the unique motor weakness. Sensory discipline are often bilateral, not necessarily serviceable and asymmetric system. Neurological dysfunction is perceived and can even worse sharply with sudden paralytic lateral and uric incidence. intestinal bladder incontinence and sexual dysfunction occur late in the course of the disease. So the pain occurs in the 15 or 16% of patients. So it's really not the patient symptom. So most of the patients come to our hospital. The first complaint is about the glandular pain. And the real sense of the symptom several hemorrhage. And the difficulties in the diagnosing. So the duration of this disease will be a few days or a few years. And the people with this disease will generally old and with the difficulty in communication and the poor willingness to seek medical treatment. And the intervertebral discal hemorrhage and spine games. And this disease will lead to the misdiagnosis and improper operation. And delayed diagnosis resulting in this person severe motor sexual and attempts, and with 10 to 13% of patients require wheelchair assist at the time of diagnosis. So some people come to our hospital, so they are too late. So diagnosis, we more use the MRI and cold episode signal on T2 investigates the cold edema, present 19% of the cases. And the cold MRI may focus on campus in continuous segment, rarely whole cold element front. And T2 have a large powerful weight, the corner rate, especially dura to the corner with the subhemorrhage, we paint in gorge veins, present nearly 18% of the cases on routine MRI. In larger veins in the subhemorrhagic space can be better detected on the heavy T2 sequences, and the vessel appears as splinting feeding defects. The enhanced with the code on the T1 post-contract infection may be due to the venous incompetence and the disruption of the BBB. It's usually direct at the age stage, and in course of disease is straightforward aggressive growth and the damage code late in the disease growth. The code might be show atrophy. So we can see this MRI imaging the cold edema in large veins and the enhancement of the coldness in patients with one long-standing history of spinal AV fistula. And the MRI of the patient with the AVF have a symptom for 1 more year, showing the classical finding the cold swelling and a high signal at the center of the cold. And multiple enlarged veins in the subhemorrhagic space can be seen at the full wheels. So the DES is still the golden state for the diagnosis. So the normal span DSA with no evidence of the physical, but we see that the iconographic hallmark of the SDV is early filling of the enlarged radial vein run into the middle and the filling of the multiple enlarged subtending drain veins, the coronal veins in the ascending or descending direction. And the anterior spine artery is characterized by the slow fall and stay due to the cord edema and venous congestion. And how to treatment? It is 2 ways. One is endovascular treatment and the traditional surgery. In the endovascular surgery for the SDAVF, liquid glue or the onyx just inject to permanently glue the medial side of the fistula. And it is essential to completely fill the upper part of the radial vein in order to prevent the reconsolidation. The surgery is preferred over and vascular treatment to avoid the accidental inflammation, and the surgery also preferred in children with total feeders and cannot be safety raised close enough to the fistula. So our location in which is our preferred surgery, traditional transmission. The surgical conclusion of the thing is simple and safe. So we open the dura and identify the radial vein for this vein, and we can find the dura attachment and the fistula point. And we concentrating for clipping the vein and its attachment to separate from the dura. Effective closing of the dura is detected by immediately changing color. So you see that the picture, and we talking collection the fistula, the color of the vein work into the dark, into the blue. And the only location in which such endoscopy is difficult is the sacral region. So a mental analysis performed by 1924 from the success rate of the opening surgery is nearly 98%. And at that time, the endovascular ablation is 46%. However, with the instructional technical approach and the diagnosation of microcyclicity and golden experiments with the technique, reported a rate of successful and the researching had been raised to 17 to 18%. However, in our century, owing to the high cure rate of the surgery, patients are sent direct to the opening. So many cases in our center is do the traditional surgery. We did not do the endovascular disease. So we see the cases. The case 1, the T7, is a male patient, 62 years. The both lower limbs has numbness and weakness for 3 years and worsened for 3 months. After opening the dura, we can see the enlarged veins just in the subatomic hemorrhage. We do the SAG. We just clip the fascicle. When we release that, we can see SAG picture. The enlarged vein will brighten again immediately. So that means the fistula is only one fistula in this disease. After we confirm the fistula, we just cut off this fistula and make sure the node will connect again. After we do the surgery, you can see that the color of the enlarged vein will get into the color to red to the blue. And then after the surgery, we do the DSA test immediately after surgery, so we can now see the fistula and the enlarged veins. Aaron case 2 is a male, also is a male patient, 62 years old. The chief complaints with the numbers and weakness on both lower limbs for 1 year and gravitation for 2 months. The physical examination showed that a grade 4 muscle splinter of the both lower limbs and hematocytes between the kidney. So the MRI showing that the cold swelling and multiple enlarged vein in the subaortic space. And we also do the DSA test. We can see this fistula may be located under the T4. And we opening the acromion membrane is open. We can see that the red circle is shows that the fistula. During operation, I identified the fistula temporarily blocking. The ICG was confirmed. Just like the last one, when we release this clip, the enlarged vein will come brighten again. Then we corroborated the fistula. That's the DSA test before and post surgery. After 5 days post surgery, and this man's spine cone edema is getting better. The last cases is also the man 17 years old. The chief complaint was also the numbness of the lower limbs with weakness for 2 years. The fixed examination showed that grade 4 muscle strength of both lower limb has healthy below the kidney level. And this one also said MRI showed that the cold swelling and multiple enlarged veins in the sublunar space. We do the test. We find that the location of the fistula is after T4. The same thing, we just temporarily block the fistula and released. The enlarged vein will come right again. So this one is also shows that this fistula is the only fistula in these cases. We also do the flow 800 in the test of these cases. After surgery, we can see that the fistula and the enlarged veins are all disappeared. And the spine edema will get better. So the estimated clinical prognosis post-operative recovery depends on the severity of disease at time of treatment. The duration of the disease before treatment is also an important factor. Prolonged severe edema and spine cone enhancements, severe neurologic fix, and the spine muscle dysfunction are signs of the poor of the prognosis. Approximately 80% of the patients have some clinical improvement, and remain patients did not show any improvement, even with the fistula conclude. And some patients were getting worse. and ischemia of recovery better than the central orders, and the swing orders were more likely to persist or improve slightly or surgery. And a sacral dysfunction in the patients with long-term disability very rarely reversed. Pain, especially the foot pain, also persist after surgery. So our patient after surgery always complain about the pain. The mechanism underlying identification to improve the impulsion to prevent the deterioration after surgery are unknown. In addition, in some patients whose condition occurs rapidly, such as with acute epileptic and the significant dysfunction, emergency treatment may significantly improve the symptom with a few days. Thank you. That's all my presentation. Thank you.
Thank you, Dr. Yu. That was a very nice presentation, and I really enjoyed. So, Dr. Raja, are there any questions
So
in the
far,
chat
we
box?
have none in the chat box.
Right. So
Dr.
I'll start.
Lincoln, can you just on your video? We cannot see your video. Dr. Lincoln, yes.
I think he has unshared the screen probably. Oh, okay, Dr. Wu. Very nice presentation. So I have personally have experience of operating on some of these patients, including patients where endovascular treatment was tried, which led to transient resolution of symptoms, but symptoms eventually returned. Because as you know, it is very important to take care of the vein, at least some segment of the vein, along with the fistula for persistent cure in such cases. So in your experience, which are the cases which recur even after successful surgery? Have you had any such cases, Dr. Lingun?
Yes, if some people will come to my center with very severe symptoms, so they will recur the symptom very high. If something the symptom will come very rapidly. So after emergency surgery, the recurred incidence is very low. So I think it depends on the severity of the symptom when the patient come to accept the treatment. I think this is one very important part.
Okay. So we have a question by Dr. Harshad Parekh, who is asking, have you operated any patient with paraplegia with the spinal dural AV fistula? And if so, how did that patient fare? Did the patient improve? Dr. Lingun?
Yes, we just when we cut the fistula, we just make some protection of the spine course and avoid the heat damage to the core tissues. So, and we lower the power of the tissue. So if it's no problem, we just do the cut off the operation.
Okay, so basically what he's probably trying to ask is, any patient who came to you with preoperative paraplegia, means no power in the lower limbs, then you operated on that patient for fistula, and did the patient improve after surgery? I think this is what he's trying to ask.
Yeah, if it is a patient that come to have cost with paraplegia, so we did not want to do some surgery to that patient because the patient recovery very, very, very difficult, and most of people did have some benefit from the surgery. So if the people with the paraplegia, so we didn't recommend the surgery.
Right. So I have an experience of operating on such a patient. So in my experience, those patients who have weakness in developing in the lower limbs pretty rapidly in a very short period of time, and if you're able to operate on these patients right on time, then they show a great deal of recovery. The problem arises in patients who have paraplegia for a longer duration, say 5-6 months or maybe more. So those are the patients who are not likely to show any great improvement. So I think the timing of intervention from the beginning of the symptom is what matters most. And those who present with paraplegia of short duration with clearly defined fistula point on angiogram, I think after discussion of the patient, we can offer them surgery, but we have to explain it to them that the improvement may not be complete. So I think this is one. So
Yes.
yeah, Dr. Lingun, do you use intraoperative neuromonitoring during your surgeries in such patients?
Yes, there's often we use every cases we use the motor.
Right. Fine.
If I may ask one question to
Yes,
Dr.
please go ahead.
Dr. Lingan, if there is no ICG in your place, are there any other methods where you can judge that this is the correct fistulous point?
You can just temporarily block the fistula and wait for 10 to 15 minutes. And when the enlarged vein get color to blue, that means the block is very right point to this patient. So you can do the cutoff. I think this is the method if you don't have the ICG as an good method.
Thank you.
Yes, Dr. Raja. So in my experience, the most important thing is preoperative localization of the fistula. So preoperative DSA, cannulating each and every of these intercostal arteries. Sometimes sitting down with your radiologist to find out exactly the point. Like the radiologist will definitely tell you that the fistula point is somewhere between say T6 and T7. Okay, the intervertebral foramen. So intraoperatively reaching that level with CM guidance or whatever guidance you have. So localizing that area is very important. And once you open the dura, I have seen it many times that all you have to do is search for the nerve root on that foraminal side, say T6, T7. So you'll typically find one vessel which is going along with the exiting root and it is getting attached to the dura. This is not a normal anatomy. You'll never find such a vein going with the nerve root attaching to the dura. So if you find that, then it has to be the fistula point. You can just occlude that with a temporary clip. And as Dr. Yu has said, you can probably wait for some time and you'll see that the spinal cord congestion has reduced. The color of the vein has reduced, but it will take some time. But of course, operating these patients with ICG is an excellent tool. I think no better use of ICG can be recommended except cases like this. I think this is paramount if you're planning to operate.
Yes.
Right. So co-panelists, if they have any questions, Dr. Lin, any other questions?
As of now, I'm just want to comment that the lecture has been very comprehensive and very understandable. It has shed, I think, a light on this because I personally had a patient like this. I will share that before he consulted other spine specialists, and they were just diagnosing him to have spondylosis, so that the pain that was coming from his back, and then later on he progressed to having motor dysfunction. So it's what's only then that when he consulted me, I requested the angiogram, and it was proven that he had pleural AV fistula. So he was operated on. But then again, at this time, he has some residual spasticity on walking, but he can walk already after he became paraplegic. Okay, so that is really a very misdiagnosed and rare but common, condition.
Yes, in fact, in my own experience, I happened to operate on a patient thinking it to be an intramedullary tumor because the spinal cord was swollen and his symptoms were of subacute myelopathy. And the radiology was not of good quality, so we missed the serpentine flow voids on T2. So we opened up the spine, we opened the dura, and we found arborization of blood vessels, and we immediately knew that we are not dealing with normal intramedullary tumor. So we aborted the procedure. We went for a DSA, and we realized that this was actually a spinal dural AV fistula with congestive myelopathy, which was manifesting as intramedullary tumor. To intervene as early as possible.
Thank you very much. I think it was a very wonderful session. We learned a lot. Thank you, Prof. Kuntal Kantidas and Professor Wu Lingyun for this wonderful session. I think it's time we can wind up this webinar now. Close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I'd like to thank both the speakers of today, Prof. Anwar Ahmad and Dr. Lingyun Wu, and the chairs, Prof. Lin Lucena and Prof. Kuntal Kantidas, for these wonderful sessions they have chaired. And also special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. Until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.